Hello again, everyone. It has been quite a while, but I am back per some of y'all's requests. Um, I am really pleased at all the feedback, the positive feedback I received on that last video where I looked crazy. I decided to look somewhat presentable this time. But this video, I'm coming to talk to you all about my life as a labor and delivery nurse. So I started back in August and it's now February, so it's been a little bit over half a year. I've been off orientation for a month exactly, and things are going well. You know, I'm learning a lot. There's a lot to learn, which is something that I love. There are down days and up days, but all in all, I'm loving my job. I will be discussing with you all some of the tasks that we do as a labor and delivery nurse, as well as, kind of a general routine, which really it varies depending on what patient you have and where that patient is in their care. And so that's what this video is going to be about. So if you are interested, stay tuned. First things first. So some of the tasks that you do as a labor and delivery nurse. One, cervical exams. So that's seeing how dilated a mom's cervix is. And you want it to be 10 centimeters because once she's 10 centimeters, she can start pushing. So you get skilled in that, doing IV starts, managing medications, recovering patients, as well as doing various things to progress labor, such as positioning, might be managing medications. All those things are a part of labor and delivery nursing. So for my routine, so I come into the hospital. I work night shift, by the way. I come into the hospital and I go straight to the locker room to change into my scrubs. Now, my organization, we're not allowed to wear our scrubs to the hospital. We actually have to change into the scrubs that they have cleaned. I'm not too sure why. I have a feeling it has to do with the fact that we go into the OR sometimes if mom has a C-section. So they want us to be as clean as possible. But it's not a big deal. I don't mind it at all. So I go in, I change into my scrubs, kind of get all my pens out, my report sheet out that I like to use, and I make my way upstairs to the unit. I meet with the nurse whose patients I will be receiving, and I get report from them. So with report, I'm basically learning about my patients and where they are in their patient care. So that includes learning about their health history, including like significant medical history, the reproductive history, and their obstetric history as well. So learning what baby this is for them, learning how many weeks they are, their due date, learning about any allergies they have, medications that they're taking, and then as well as learning what orders the provider has in place for them. So I'm kind of learning all these things about my patient, and once I've received my report, then I will go into my patient's room and do my initial patient assessment. Now, this isn't kind of like your traditional head-to-toe assessment that we learn so well in nursing school, but rather it's a focused assessment. So I'm looking at both baby and mom. Those are kind of like two patients I have in one room together. And when I'm looking at baby, I'm looking to make sure the heart rate looks good and is not, a lot of decelerations. Baby's having some good movement, good variability. And then I'm looking to see that mom's contractions are adequate as well. Also, I'll be taking mom's vital signs, doing a line reconciliation, and that just means I'm making sure that any medications or fluids that are hooked up to mom's IV lines, that they're hooked up to the right place. We don't want to see an epidural catheter line hooked up to a bag of fluids. That would be like a big no-no. And you also want to make sure that the fluids, they're running at the rate that the provider ordered them to be running at. So you'll do line reconciliation, and what else? We do IV starts as well. And then another task, which is a big one, is progressing labor, and that's through both, medications as well as through like natural positioning and other ways to kind of help a mom move through labor and cope with labor, okay? Because that's the goal, is to get mom in labor and to make sure she's progressing. So that leads me to laboring patients and kind of what that entails. So depending on both the patient's wishes as well as the provider's orders, laboring a patient might involve different positions. Often I like to go for more upright positions because you're using gravity in your favor. If you're laying back in bed with your legs up, I mean, you're not really helping that baby to move down and to further dilate the cervix. Often, if a mom wants to go natural, another position that I like to recommend is having her get out of bed, and I'll raise the bed all the way up so that she can kind of lean over it or lean over some pillows that I place on the bed. And I tell her to kind of have her legs wide open and kind of rock her hips when she's having a contraction. If she's having back labor, I'll tell her partner to kind of apply a counter pressure on the back of her hips. And that kind of just helps to open that pelvis up. I don't know why I'm doing it this way. Helps to kind of open that pelvis up and relieve that back labor pain. So they often like that. There's rocking chairs that we might have them use, birthing balls. I mean, then the options are endless. Another way we progress labor is through medication, if indicated. So the provider might order for us something called Cervidil. What the Cervidil does is it helps to soften that cervix and really prepare it to go into labor. Pitocin is another drug we might administer, helps produce those contractions, okay? And my job as a nurse is to keep a strong eye on the Pitocin, making sure that both baby is tolerating it and mom is tolerating it. I usually check her or do a sterile vaginal exam about every 4 hours. I might do it sooner if she's, requesting pain medication or let's see, I might not do it as frequently if her water has broken because then we don't like to do it frequently at all because we don't want to keep introducing bacteria up into her vagina. So now we've been laboring with mom through positioning, medication, both, and I check her and she's 10 centimeters. Woohoo! All right, this is the fun part. This is my favorite part, okay, is the actual delivery. It makes me feel like all my hard work, all her hard work has paid off. So I'll call the provider, which might be a midwife or OBGYN, and let them know. And then I'll tell the technician, my labor and delivery technician, to, set up the room for delivery. And they'll just kind of get a table set up with some of the supplies the provider will use to help with the delivery. Tech will get the baby warmer prepared with blankets and the baby's hat, and such. So the provider comes and I just love this part. So we start pushing with mom. Usually I will hold one leg and then the mom's partner will hold the other leg with the provider right in the middle, ready to catch the baby. Both myself, the provider, and the partner will all together as a team, and the mom will be her cheerleaders to help get this baby out. So the hardest part of pushing as a nurse is kind of making sure everything's in place and making sure that baby is tolerating mom pushing, okay? Because you have to remember, when mom's pushing, she's holding her breath. And if mom's not getting oxygen, baby's not getting oxygen. So it's normal to see a little dips in baby's heart rate, but we become concerned if baby's kind of having constant dips in their heart rate and they become longer than normal. So I have to kind of use my other hand to keep that external, I don't know, I keep on going like that, to keep that on baby and making sure it's picking up baby's heart rate. So that's one of the trickier parts. But as soon as you start seeing that baby's head kind of crowning, then I'll ask the technician to grab me a blanket from the warmer so it's nice and warm, and I'll place it on mom's chest, and next thing you know, mommy's delivered baby. We get baby onto the blanket, and it's my job to dry and stimulate baby. You want that baby to be crying, getting that fluid out their lungs, and then the cord will be cut, usually by the partner. And then if everything looks good with baby, then we will place baby skin to skin with mom. Usually, depending on if mom had any lacerations, which is like tears in the vagina area, then that's my opportunity to kind of catch up with my charting. From there is recovery period. So recovery period starts as soon as that placenta is delivered. So usually, actually, whenever baby's born, I'll push the call bell button to get someone out outside the room to grab a bag of Pitocin. I like to start Pitocin after the placenta is delivered, and that is to basically help that uterus kind of clamp down where the placenta was attached, because otherwise those vessels will be wide open and blood is just rushing out. So that helps to Pitocin helps to clamp the uterus down. Then we cleaned up everything. We cleaned up mom, get an ice pack to her perineum, and get her some juice and crackers. And I'll start my fundal assessments then. And the fundal assessment is just rubbing on the top of the mom's uterus, and that's to also help make sure that it's nice and firm. About 30 minutes after mom's delivered, nursery will come in and do a full head to toe assessment on baby, and do baby's first bath and all that good stuff. So my primary responsibility is looking at mom's bleeding and vital signs and pain level. So as long as everything looks good from there, bleeding, I'll get mom cleaned up with a new gown, pad and panties, and helping her to the bathroom for the first time if she's ready, and then getting the epidural catheter out if she had one of those. Basically the gist of everything. So yeah, let me know if y'all have any questions about some of the things I do as a labor and delivery nurse. And I will hopefully try to make a video a lot sooner than 6 months this time. Thank you all for watching, and I'll see you on the next one. Bye.